Hello everyone, my name is Ashim Bhatia. I'm a pediatric neuroradiologist at the Children's Hospital of Pittsburgh. I wish we could be in person for this conference. I do have this lecture on congenital torticollis. Happy to present it, and will be available for live questions soon. I'm a consultant for Group A. The outline will be some background information, normal anatomy, and causes of congenital torticollis. Also got a question here that will be answered during the presentation. What is the cause of torticollis in this infant? In this case, what is causing torticollis in this infant? Do you see the abnormality? We also will review this case during the presentation. So what is torticollis? It's a congenital or acquired deformity characterized by a rotational deformity of the cervical spine with secondary tilting of the head. So here's a good example of a kid with torticollis with the head tilted. And with congenital torticollis, this is a sign of underlying disease, but it's not specific. So there could be multiple causes. You can have muscle, bone, CNS causes. We'll discuss the most common ones. The other thing to remember is congenital torticollis has a different etiology than acquired torticollis. Here's an interesting retrospective study that looked back at patients with indications for congenital torticollis. And what's interesting is the majority did not need imaging. So here, about 93% never needed imaging. And very few persisted after 1 year. So majority actually do resolve. An important structure in relationship to congenital torticollis is the sternocleidomastoid muscle. Origin is at the manubrium of the sternum. Insertion is on the mastoid process of the temporal bone. Main action is really the flexion of the head and elevation of the chin. So when you look at the MRI or ultrasound findings of the sternocleidomastoid muscle in a normal patient or a normal muscle, you can see the muscle is hypoechoic. This is the grayscale ultrasound with echogenic lines that represent the normal paramecium. And in the MRI sequence, you can see that the sternocleidomastoid muscles are, for the most part, symmetric in size, have homogeneous signal. So let's look at muscular causes of congenital torticollis. Alright, so congenital muscular torticollis is the most common cause of congenital torticollis. It's usually unilateral, and it really refers to a group of disorders. So fibromatosis coli is when there's a palpable mass in the sternocleidomastoid muscle. Muscular torticollis is tightness of the sternocleidomastoid muscle without a clinically apparent mass. And postural torticollis is neither mass nor tightness of the sternocleidomastoid muscle. So for fibromatosis coli, the ultrasound is a modality of choice for the evaluation. 70% of cases are between birth and 2 months of age. For some reason, the right side is more common and very rare to have bilateral involvement. And usually the involvement's in the lower 2/3 of the muscle. Fibromatosis coli, you'll see the diffusely enlarged sternocleidomastoid muscle, usually like a fusiform configuration. It also can be a focal mass, and the echogenicity is usually heterogeneous, more likely going to be hyperechoic. And some literature has supported the diameter from 8 to about 16 millimeters, but it's also the asymmetry in the size that's very helpful. You also see irregular margins of the mass. And just remember, x-rays are not very beneficial in these patients. Really, your first study should be an ultrasound. Also important, if there's extension of the abnormality on ultrasound or cross-sectional imaging beyond the sternocleidomastoid muscle, you should think about additional causes. So one of the challenges with the sternocleidomastoid muscle is the physiologic growth. So this ratio of the involved sternocleidomastoid muscle to the intact muscle is one way that could be helpful. So if you look at A and B in these figures, this is that presentation. So you have involved on the left, uninvolved on the right, and after 3 months, there was increase in the uninvolved muscle and slight increase in the involved muscle as far as the thickness. But if you look at the ratios, it actually went from 1.5 to 1.26. So this was resulting from physiologic growth, and this is where this ratio can come in, can be handy for these kind of situations. Here are some of those examples I have. So again, grayscale ultrasound shows a focal hyperechoic mass in the right sternocleidomastoid muscle, unaffected on the left. Color Doppler, really no significant vascularity, so there's no mass in there. It's just the fibromatosis coli, or enlargement of sternocleidomastoid muscle. There's a cine loop of sternocleidomastoid muscle just showing the enlargement of it. Not very exciting there, but gives you an idea of what's going on. That's probably a little more exciting. Or this dog leaping. So let's go to that case of what is the cause of torticollis in this patient. You have this focal enlargement here. Kind of difficult to tell what's going on. But if you look at it, it's actually just focal enlargement of the sternocleidomastoid muscle. Post-contrast sequence. And so this is fibromatosis coli. It's not an enhancing tumor. It's not an aneurysm. And it's not a lymph node. It has probably a little better image of it. So now you have the coronal sequence, coronal T2, showing that focal enlargement of the right sternocleidomastoid muscle. And relative to normal muscle, it can be T2 iso to hyperintense. And depending on the T1 sequence, can be slightly hyperintense or isointense. Here's another example, focal enlargement of the right sternocleidomastoid muscle, uninvolved, and color Doppler, really no significant vascularity. Cause of treatment, I think it's unclear the exact cause, but some suggest that it could be a birth trauma with a hematoma in the compartment. Most cases spontaneously regress without deformity, most resolve without any issues, and some can progress to muscular torticollis despite therapy. So they do have to be followed, at least in some cases. And this is actually in the literature, so this is something you don't want to do. Is chiropractic manipulation of an infant with congenital torticollis actually resulted in quadriplegia because there was an underlying problem there. It was actually a spinal cord astrocytoma causing the torticollis. And these are unusual cases, but reasons that a clinical workup should be done first. Here's muscular torticollis. It's just in the spectrum of fibromatosis coli, 73% present after 1 year of age. Another unusual cause of congenital torticollis is unilateral absence of the sternocleidomastoid muscle. So here on ultrasound, you can see there's no clear muscle. Well, on the right there is, and this is MRI showing that abnormality where there's a muscle on the right but nothing on the left. So absence of the sternocleidomastoid muscle can also be one of the causes. And we'll look at bone causes just briefly. You can have multiple congenital anomalies of the craniovertebral junction. Radiographs are good screening to start off to look for the segmentation or vertebral anomalies. And the vertebral bodies that are widened and flattened, you should think about Klippel-Feil syndrome. Here's just multiple examples of Klippel-Feil syndrome, the multiple vertebral anomalies that you can see. So very easily can be seen on radiograph, but obviously CT can help further characterize these abnormalities, such as this case in occipital fusion, where you get suggestion on radiographs, but really much more easier to depict on CT with these 3D reformations as well. All right, let's look at this cause. This is one of the cases that I showed earlier. What is the abnormality? Can you point to the abnormality causing torticollis? So frontal radiograph of the cervical spine. And there it is. There's a density there in the upper cervical spine. So what is that? Let's take a closer look. There's a lateral radiograph. Here you can see calcifications at the disc level of the cervical spine here. So this is actually at the C3, C4 level. You can also see it on CT here even better. There's a sagittal reformation. There's intervertebral disc calcification and some retropulsion of these calcifications. Sagittal T2. Harder to see the calcifications, but you can see the narrowing of the cervical spine at this level. Maybe some minimal mass effect upon the cord, as well as on the axial T2. And so this is actually intervertebral disc calcification. Well, an uncommon cause, I've seen a few cases of this. The good thing is it's treated conservatively with braces and NSAIDs, and in most cases you get complete or almost complete resolution. This example, after 9 months, there was almost complete resolution of those disc calcifications. So as I mentioned, it's very rare in children. Could be seen in like some degenerative or metabolic causes in adults, but haven't been seen in children. Most often cervical spine, as we saw in this case, variable clinical presentation. Conservative management is needed and surgery is rarely indicated in these cases. Here's another example of the intervertebral disc calcification. So important to keep in the differential. The radiographs will help first depict the abnormality, and then cross-sectional imaging, most likely CT, will be the best next step. You can see in this case there's pretty significant spinal canal narrowing from it. But look, after just a short time, this is within 3 months, where you saw initially on presentation that severe narrowing and mass effect on the cord. There's almost complete resolution of that. Very minimal spinal canal narrowing, if any. And this study looked at some of those cases of intervertebral disc calcification and look at the age of some of these patients, 8 days old, 10 weeks old, 6 months old. So very young patients can present with these abnormalities as far as intervertebral disc calcifications. Also, like I mentioned, other possible causes of congenital torticollis can involve the central nervous system, such as in tumors. Intraspinal tumors can cause congenital torticollis or torticollis. In an infant, here's an example, ATRT, which can present in kids in less than 1 year of age. Here's another example, different patient with mass extending intraspinal causing mass effect on the cord. This is a post-contrast sequence showing this mass shows reduced diffusion. Here's actually tractography showing the cord being displaced. So here's the cord on the post-contrast sequence. Here's an enhancing mass. And this turned out to be another antegumental teratoid rhabdoid tumor. Other causes I'll go through just briefly to highlight them as carrier 1 malformation. That can also cause torticollis, so something to keep it a differential. Infection, another common cause. This can also be imaged looking for the tonsillitis, lymphadenitis, other findings consistent with infection. Trauma should always be in the differential, so that also will be screened with imaging, radiographs, and CT is really the best modality for that. But in summary, the differential for torticollis in infants is distinct from in older children. Congenital muscular torticollis is the most common cause, and ultrasound is the first modality of choice in infants. And here's some of the references, and look forward to any questions. Thank you again for having me, and hope we can do it again in person in the near future.